And now to close us out, Ashley St. John from Duke, Singapore.
All right. I'm absolutely thrilled to be here. Thank you, Adam, for the invitation. And I'm just going to jump right into it and try to not stand between you and lunch. So, how I'm thinking about dengue and dengue disease, I think is illustrated by this diagram, and I've had the opportunity to have everyone introduce all the background for me. So we think of dengue being something where you have this initial febrile response, and then only towards the time points of disease resolution do we start seeing this risk of severe disease. And I'm trying to make an argument for the idea that really a lot of those immune responses that are established early, very early in this incubation period, and this period of time when your immune system is first responding to and detecting the virus, are really critical not only for the immediate responses in terms of downstream severe disease, but also may set you up for later in your life having different types of responses to dengue. And so starting with just this idea that dengue begins in the skin with the injection of the virus by the mosquito. And of course, we know that there are targets, innate immune targets of infection in the skin, like dendritic cells that can pick up the virus and take it to the draining lymph node. But we also see that there is a pro-inflammatory response. Of course, we know if you don't have interferons, which are an important innate immune response, you have much more severe disease. And if you don't have certain cell types like mast cells, which we started studying 15 years ago now with dengue, you also can end up with higher viral titers and reduced protection against dengue. And so starting from that concept, I just wanted to highlight that one aspect of what we saw mast cells were doing is recruiting in a lot of innate immune cells into the skin tissue site upon infection. And in particular, we saw that T cells were recruited. And among the T cells that were recruited, we saw that NKT cells or other innate-like T cells were also recruited. And so we then wanted to ask, what are they doing? Are they contributing to protection, and how are they doing that? And so the first question that we started asking was related to how are CD1D restricted or iNKT cells potentially contributing to dengue clearance. And so, of course, T cells are a diverse population of lymphocytes. We have these inflammatory NKT cells that have a restricted TCR. They recognize this alpha-gal SIR on CD1D, the non-classical MHC molecule. We also have type 2 NKT cells. They have been associated with autoimmunity. I'll just say we don't really see them very much in responding to dengue, so I'm going to ignore them from now on. And then we have a diverse population of T cells that can't really be picked out with any individual tetramers at this time, like some of them can be, but this is a really diverse population of NKT-like cells that also contribute to the inflammatory response. So we started in the mouse model with dengue infection, just trying to describe what we see in terms of the types of NKT cells that are recruited immediately following infection. And we saw that over this time course of 5 days, we see a peak at 3 days of NKT cell recruitment, particularly type 1 NKT cells. And we have the opportunity to use CD1D knockout mice because of using the mouse model. And in order to do this, of course, we wanted to continue like the flow cytometry interrogation that we were doing, and also look at the kinetics of infection. And the first thing we saw is that without these type 1 NKT cells, which are, of course, a very specific subset, we not only get no recruitment of them, they're not expected to be there, but we also get no recruitment of other subsets of NKT cells. So the type 1 NKT cells are very important for the recruitment of the diverse type 3 or NKT-like cells as well. And when we sort these cells out of the lymph node, we can look at their TCRs, and we see that in the wild-type mice, we have a very diverse TCR repertoire that is increased. As you can see in the graph, the diversity index is increased with dengue infection, so we're starting to see some rare clones are coming up and becoming more abundant and detectable, but this doesn't really happen in the CD1D knockout mice. So these mice really lack this efficient NKT cell response, both in terms of this invariant subtype as well as the diversity. And then I want to also add that This was not only NKT cells, we also saw an effect on CD8 T cells, and importantly in the bottom panels, this also correlated with the resolution of infection. We actually expected to see, since the response is so early, that perhaps at day 3, the early protective response might be impaired, but this only seemed to be in the late stages where we had impaired clearance of virus. So the postdoc working on this, his name is Youngju Choi, he made this really interesting observation. We were thinking there's something to describe here, but not too much, and he got really excited about the fact that the cytokines these T cells were making were also very different in the absence of NKT cells. That we saw a much higher production of IL-4, a Th2-associated cytokine, and a much lower production of interferon, of course, a Th1-associated cytokine. And overall, and if you look at the chemokines produced and other factors, this was characteristic of a shift from a Th1 type response, which we know has been associated with viral clearance in many different systems, to a Th2 response. So then we wanted to really understand, okay, is there something about the polarization of these T cells that can be transferred into recipient mice? And can we really identify what is being produced by the NKT cells that's leading to this effect? So we used T cells from either wild-type mice or from interferon knockout NKT cells, and we transferred them into these CD1D knockout mice. And we wanted to see what the effect of interferon or Th1 polarization might have on the resulting infection and disease. And then in the recipient mice, of course, we challenged them with dengue, and we looked at them by flow cytometry. And again, we can see that if NKT cells can produce interferon, this leads to a shift for the CD4 T cells that are, of course, very important for producing antibody responses, as well as CD8 T cells. So that, again, just the presence of interferon production by the NKT cells can lead to a polarized Th1 immune response in the T cells of the recipient mice. And then we also looked at the antibody profile, because of course, not only do T cells make cytokines consistent with the Th1, Th2 sort of phenotype, but antibody subclasses also are associated with Th1, Th2 subtypes. And so we looked at IgG2A, a Th1-associated antibody, and IgG1, a Th2-associated antibody. And again, we saw the same shift that in CD1D deficient mice, they have reduced IgG2A or Th1 type antibody responses and increased IgG1 or Th2 type antibody responses. And so just to summarize what we think is happening in the tissue, and there's some parts that I left out for the sake of time and so that I can get to also some news stories we haven't published, we see that infection in the skin leads to, of course, infection of dendritic cells that can migrate to the lymph node, but also recruitment, activation of mast cells, and recruitment of other innate lymphocytes into the skin. And particularly important are these type 1 invariant type NKT cells that are major producers of interferon, that this drives a shift in the T cell response and the NKT cell response, leading to really improved Th1-associated immune responses, both in terms of T cells as well as antibodies. And so what happens in humans? So for this, we looked in a cohort of primary dengue patients from Sri Lanka. Professor Minori from the University of Colombo provided us with these samples. And we looked at their antibody responses as well as their cytokine responses. And we saw that, again, there was this very interesting correlation where, for example, I think you can see a very bright dot of yellow out to on the far right side for you, is the correlation between TNF and IL-10, and IL-4, I'm sorry. And this is, of course, a Th2-associated type response. And we found that these interesting clusters of patients had either a Th2 type cytokine profile or a Th1 type cytokine profile. And we also saw that in patients that have IgG3, which is associated with a Th1 type human response, we see higher levels of granzyme K. And granzyme K isn't necessarily specific only for NKT cells, but they're very major producers of it in humans. So again, we saw this correlation between the antibody subclass and really efficient induction of NKT cell type responses. So then we asked, okay, how would Th1 polarized antibodies function during a secondary exposure to dengue, looking beyond our primary infection, but what could be happening during secondary dengue? And so to start looking at this, we started in the mouse model again. We used our wild type and CD1D knockout mice to produce antibodies after primary infection. We purified them so that we would have exactly the same amount of antibodies and concentration of antibodies in each case, and used this process of making immune complexes with either homologous or heterologous virus to then study infection outcomes in recipient mice. So then looking at the titer of dengue following this ADE type assay, when we saw that when we look at homologous infection, of course we expect antibodies to be protective. And in fact we do if we use wild type IgG and complex it with dengue 2. We see protection. However, when we use the IgG from the CD1D knockout mice, we don't see protection. So already, these antibodies are shown to be weaker and unable to fully control secondary infection. And then in contrast to that, when we look at heterologous challenge, when we complex the antibodies with a different virus, in this case dengue 1, we again see that we are able to see ADE even with dengue 1 alone with the wild type IgG as expected, but the ADE is even enhanced if we use the antibodies of CD1D knockout mice. So these antibodies are really weak antibodies. They don't do a good job of protecting against homologous infection, and they also lead to enhanced heterologous infection, even beyond the normal ADE response. So then what about in humans? So here, this data is from patients with secondary dengue, and I think you can hopefully see where the DHF column is. All these little X's are patients that were diagnosed according to the clinicians as having DHF, which is the criteria that's used most often in Sri Lanka for severe disease. And if we look at our IgG3 on the left and the IgG4 on the right, we can see that there's this also association of a more Th2 type, IgG4 high type immune response with patients who have DHF compared to patients who do not have DHF. And you can see that in terms of the titers as well. On the right-hand side, the patients with high levels of IgG4 going into their primary infection. So these are samples that were taken as soon as they were diagnosed within 3 days of fever onset. They had much higher levels of IgG4 to start. So what we think is happening overall is that these NKT cells are on the top, in the normal condition on the top panel, leading to nice induction of interferon, production of chemokines that are associated with efficient trafficking in the draining lymph nodes, and that this is leading to polarization of immune responses, both in terms of these nice cytotoxic T cells that you want to achieve during an early primary infection, but also in terms of Th1-associated antibodies that we think are associated with heterologous infection control. And in the absence of these NKT cells, we see weak responses in terms of CTLs and Th2-associated antibodies that in our hands were associated with increased ADE. So I kind of want to just highlight, at this moment, what we're thinking of in terms of how the innate system is working during dengue. And I think, maybe to answer partially this question that came up this morning, is BCG good enough? And I strongly think BCG is not good enough because not only is the innate immune system a target of infection, and of course you can activate it and make it more resistant to an infection, but when you're talking about the adaptive immune system, it's being molded and modified in the presence not only of innate immune activation, which is very critical, but also in the presence of antibodies. And, in the presence of antigen, I should say. And so here we think what's happening partially is that these pro-inflammatory mediators early on in this initial recruitment are really essential, particularly subsets of T cells, innate T cells like these invariant NKT cells, and establishing the polarization of immune responses that can persist for a very long time. So now, just in the last few minutes, I want to show you some more data that is unpublished, that it's in press, looking at how we think of antibodies to different flaviviruses. And I think, kind of inspired partially by Eva's work, looking at the various responses to multiple flaviviruses in terms of Zika versus dengue and the sequence of infection. We also were really interested in my group looking at this question, particularly with respect to Japanese encephalitis virus. And so as we are thinking about this idea that exposure to multiple flaviviruses is increasingly likely, my group was looking for a place where we could really understand the kind of like the isolated contributions of Japanese encephalitis virus immunity to subsequent dengue disease. And this one was slow. And so we started this new patient cohort in Nepal. We chose a site called Darhan, which is shown with the little yellow circle on the right hand side, and worked with Barendra Gupta from Nepal, who helped us establish a new patient cohort there. And we started right as the number of cases in Darhan started to rise, so we were able to recognize that they were seeming to have sequential outbreaks there every year, and we began recruiting patients in 2019. We skipped some time during the peak of COVID, and we continued then in 2022 and 2023. I'm not going to talk about all of the details of the cohort for the sake of time, but we saw a very interesting progression to having multiple serotypes of dengue present in this community. And this was also a community that had extremely low rates of secondary dengue. So less than 10% of the patients had previous dengue. And what we saw then is if we look at those patients who have Japanese encephalitis virus neutralizing antibodies, presumably because Nepal has a very high level of vaccination, maybe even close to 70 or 80% of young adults are thought to be vaccinated against Japanese encephalitis virus. We saw that particularly those patients who had a moderate titer of antibodies were at risk of having, or had a higher risk of developing severe dengue. In this particular cohort, I will say that this was a very mild cohort. So we're defining severe dengue here as severe dengue and then also those patients who had more than one warning sign. And we can see that the patients were much more likely to have severe disease if they had this low level of antibodies that we think is particularly probably associated with waning antibodies after vaccination. So, there have been a lot of studies that have looked at this aspect, and I just want to mention, of course, Eva introduced her work on Zika being linked to more symptomatic disease. Katie Anderson here, along with several of you in the audience, have looked at JV immunity being linked to symptomatic dengue as well in Thailand. And Nilika and colleagues also looked at JV seropositivity linked to dengue hospitalization, not necessarily looking at neutralizing antibodies and proving the aspect of previous vaccination or exposure, but just the idea that seropositivity itself could be a sign. And we think that looking now at the Japanese encephalitis virus vaccine, this has a particularly important meaning with respect to how we think about vaccine campaigns. Initially I was getting a lot of pushback when we sent this for review. Some of the reviewers thought that this means we should not do Japanese encephalitis vaccination. But I think that the fact that it's really linked to this low titer, and Japanese encephalitis virus is such a severe disease in Nepal, emphasizes the idea that boosters are really needed to make sure that the population has high levels of Japanese encephalitis virus immunity at the same time as they're increasingly exposed to dengue. So I hope I just wanted to kind of give some thoughts for vaccine development and refinement as I close. I think we need to look at how these early infection events or vaccination events, I think, also can influence long-term memory and immune responses, and really acknowledge that critical time window early on is so difficult to monitor, but there's something happening there that may even impact antibodies long-term. Beyond these conventional T-cell epitopes, which I'm not going to argue are not important, I think they're extremely important, but also there's the aspect of innate, like T-cells, that may even not have necessarily antigen-specific responses, but contribute to this inflammatory environment. And then, trying to achieve good antibody production, which I think has been emphasized by the previous speakers as well. And I would just like to add to that subclasses also of antibodies may be very important for generating the right type of long-term immune responses. And then finally, of course, thinking beyond this idea of tetravalent immunity, but how vaccines may function in these populations that are highly flavivirus exposed going forward. And with that, I will just finish. I'll mention that Wilfried Saron and Youngju Choi did a lot of the work on NKT cells, and Siddharth, we call him Sid, he did the Nepal study and is now back in medical school, and of course very essential collaborators in Sri Lanka, in Nepal, and at Duke University. So with that, I will finish. Thank you.